All right, good afternoon. Welcome back. Let's go ahead and get started for today. This is our second and final meeting time for week number 2, looking at patient-provider relationships. So we'll be doing a few activities, a couple videos, and some more exploration of this topic, since I think it's a crucially important thing for us to look at when we're looking at our health relationships, the way that we talk about science and health, and for a lot of you who might be considering professional work in that field, the ways that we can build some good connections and relationships there. As a quick recap of last class, we spent some time talking over the annotated bibliography that's due a week from this Sunday. Again, it's an opportunity for you to pick a topic in health communication that you find really interesting and exploring that in more detail. We started to look at patient-provider relationships and perspectives in healthcare. For instance, we were looking at this idea of a patient-centered approach that uses open-ended questions and creates a welcoming atmosphere for people to feel heard and navigating that line between professionalism and patronization. So as a kind of recap activity, let's fill in the blank. So blank involves the use of storytelling to convey shared experiences and feelings. What would be the best answer to fill in that? Yeah. Yes, yes. So great answer, Izzy, right? Narrative medicine gets at how we use stories to talk about our experience. For instance, we might use something such as a fractured narrative to talk about how we feel like our life has been in tatters and in pieces as a result of a challenging diagnosis or disease that has impacted ourselves, right? And stories matter because how we think about our health is based on the stories that we tell each other. The video we saw last class, right? A woman talks about a friend who had a brain tumor and worries that her headache could be similar to that. We like to find patterns in what we feel and experience in our own health. So just as a reminder for that annotated bibliography, do a week from Sunday. You can use that rubric on Canvas to help. And if you're hitting a bit of a blank, you're not sure what topic you want to explore or talk about, I'd be happy to help you with the brainstorming process. I just encourage you to think about some of the things that motivated you for this class, or if you want to look at in a little bit more detail. Maybe there was something that stood out to you when we were talking, for instance, about the challenges of culture, for instance. So definitely get a start on that. Maybe start to look at some of the most recent issues, terms like health communication or science communication, to get that stuff started. For today, we'll be looking at more details of patient-provider relations, kind of an inside look at the challenges of being and becoming a caregiver, right? And some of the ways in which people, from a patient perspective, experience unique threats to their agency and dignity and well-being that can come over the course of that encounter. So I want to start by thinking about, what it ultimately means for us to be a patient. There's a good chance at a point in most of our lives that we have had to come in as a patient for a meeting before. And that differs a lot depending on the context. Maybe we're just going in for a regular checkup with a doctor. Maybe we've been referred to a specialist because we've had a condition or issue that keeps popping up. Maybe we're coming in an emergency. For instance, maybe we suffered an injury, broke an arm or something similar, and want to make sure that we're getting the care and support that we need in that situation. For instance, as I mentioned a couple months ago, I was involved in an emergency room visit. I was unharmed, but I was in a car accident. And so that experience of navigating being a patient and that encounter is pretty fresh in my head and thinking about it related to these ideas. Oftentimes, when we find ourselves in the role of a patient, especially when it relates to a sudden or serious issue, we feel a lot of grief and we feel a lot of uncertainty, right? The grief being the potential loss or problem, waiting on the result or waiting to hear back on what could be potentially bad news. Not knowing what to expect going in, not only in terms of what information we'll get, but also how the encounter will go. Will the person we're talking with be respectful and support who we are? Can be unsettling too. Oftentimes the sensory experience can be especially challenging. A lot of times people talk about what it's like the smell of a hospital is really off-putting to them, right? The ways that we experience being in a healthcare setting in a sensory way can be especially challenging. We have a series of outside concerns too that can come up. For instance, as we saw last class, fears about health insurance. Is insurance going to cover this? That might be affecting things. How much work do I have to miss for this? Am I still going to be able to make my class after the appointment, right? Those fears can be in the back burner too. I remember when I was younger, and I had to go to the hospital and I did not want to stay overnight, right? And I was so preoccupied with that that I really did everything I could to try to expedite the process. Those are some of the concerns, right, that we feel. Also, some of the ways that we communicate face-to-face are very different with a healthcare provider than they are with somebody like a friend or a family member. We might value things such as direct eye contact and showing non-verbally ways that we care, but a healthcare professional is probably doing a lot of other things. They're looking at and examining your body over the course of the appointment to maybe determine and figure out how you're doing. Sometimes, depending on the situation, somebody will ask you questions or get you to talk in order to make sure that your cognitive processes are going okay. And oftentimes people are taking notes or asking questions to try to gather data. So sometimes it can feel impersonal and not connected in the same way, just based on some of the things that a provider has to do. So I think it's important as a patient to kind of take with a grain of salt the ways that we're interpreting nonverbal communication. So there's a couple perspectives here, and I'm going to ask us to explore these a little bit, going back to teams. And these two perspectives kind of match the experiences of patients versus providers. And that is what we would consider to be the voice of life world versus the voice of medicine. And I think when we examine some of the differences and the gaps that we find in how we're talking between patients and providers, these two different voices are crucial ways to understand where those differences are coming from, right? The voice of life world is a perspective that patients oftentimes have, right? It's the idea that we tend to associate our experiences of health to our experiences every day, right? Oftentimes, when we think about our bodies and we think about our health, we tend to think about it in terms of wanting things to just run normally. One metaphor that gets used a lot in both health and science communication is the idea of a body as a machine, right? And under that analogy, everything's working fine, the body is not malfunctioning, right? And as a result of that, we oftentimes become aware of health issues when they start impacting our body and how we're doing. We're probably seeing a doctor. We start having like a weird cough or rash or something that goes outside of our expectations of normal behavior. And we're more specifically concerned if we're dealing with things like work and school and other responsibilities with how a health issue is going to impact our well-being day to day. That's not the same concern that a doctor is going to have in quite the same way, right? While a doctor could be concerned about you and concerned about your well-being, the doctor doesn't live here. You live in your body. And so you feel that at a day-to-day basis in a unique way. Meanwhile, the voice of medicine is a perspective that oftentimes caregivers will have. That is, under the voice of medicine, there's a greater concern with things such as medical precision and the use of more medicalized terminology. That is, oftentimes under this approach, people are more concerned with identifying or diagnosing the issue, prescribing the treatment, and working on a way to address or deal with that, right? That is, oftentimes a provider tends to be more empirical or data-driven. They're more concerned with the hard numbers, the signs of symptoms, the specific actions that can be used to cure or support the person in whatever health issues that they have, and so on, right? And that's sort of what comes out of that profession and that perspective. However, right, it can bleed a little bit in both directions. Sometimes a patient is concerned with knowing sort of the hard information. For example, maybe you get a blood pressure check and you want to know from the doctor what your blood pressure is because you're concerned about it. Or sometimes providers can show and express and feel emotion, right? One of the things that's important to think about is a lot of times when we see caregivers or providers as like callous or detached, there's a couple things going on. One of them being that a lot of times providers have some pretty intense and serious burnout from seeing, so many situations and cases over the course of their lives. And two, that also that they're trying to navigate the professionalism and level of distance that they think is appropriate, right? So they might not necessarily be in tears every single time they have to give bad news. So there's still, though, ways in which caregivers can show and express emotion. For instance, maybe they're expressing distress or pushback because they're angry with the decision that somebody is making. Maybe there's a treatment that could be incredibly useful, but they're choosing not to do it as a patient, and there's a response there. So it's not a hard and fast black and white approach. So I'm going to have a split here. And what I want us to think about are these two different approaches to understanding and thinking about how we talk about health and science. So Rodney has broken his arm and wants to see a doctor, right? So he's been playing soccer, broke his arm, and wants to come in for an appointment. From the voice of life world perspective, what might be some of Rodney's concerns, right? What might be things that Rodney chooses to share and talk about? And then from a voice of medicine perspective, what might be some of the doctor's concerns and ways the doctor might approach this particular issue? So I think we've got about 12 people here today. So we'll start on this side. We'll do 1, 2, 3, 4, 5, and 6. We'll have this team of 6 focus on the voice of life world. And then we'll have 1, 2, 3, 4, 5, and 6 have team B focus on the voice of medicine perspective. So just take some time to chat about these two perspectives and some of the ways that Rodney or the doctor would share or talk about their concerns given that approach. So I'll give you a few minutes to talk about that and then share with the group. Give you about 2 or 3 more minutes to just chat about this. So go ahead and finish up, and when you're ready, rejoin us. So let's start with the Voice of Life World team here on this side. What were some of the concerns you all thought Rodney might have?
One of the concerns we had was recovery time,
Mm-hmm.
how it's gonna affect his future flow,
Okay.
and whether he's actually gonna continue flowing in the future. Break road,
Mm-hmm.
things of that nature.
Sure. So recovery time is a big one. Mm. Yeah. Yeah. Sorry, what was the last one? Okay. Yeah, absolutely. Those are some really good examples, right? The concerns about daily life and daily activities. How soon will I be able to use this again? How soon will I be able to play again? How serious is it? Should I be worried about it longer term, right? So there's a lot of examples here of, as we've talked about, the ways that Rodney's injury matters in the moment, but also matters for future activities. If you're a doctor, right, you might be saying, well, I don't think it's a good idea for you to go out and play again for at least the next couple months. And from a sort of detached perspective, that makes a lot of sense. Maybe Rodney really is worried about doing things like cooking, or maybe has a kid and is taking care of the kid, right? There's a lot of concerns that might be at play there that are impacting how a prescribed treatment or solution might or might not fit in that person's own life. As we'll talk about in a little bit, there's at times a disconnect that we feel when we don't necessarily take medical advice because we don't see it working in the context of our day-to-day lives and activities. How about on this side? What might be some of the concerns from the doctor?
So we said where it's broken and the type of break. Also, like treatment to whether he would need like a mask or any medication, and also like rehab afterwards.
Yeah.
And we also said family history.
Yeah, these are all really good examples, right? Family history, of course, being important. Also, right, whether or not they have other related injuries in the past, maybe whether or not medication has already been taken that could interact with it, identifying the type of injury and its severity, like that type of information, and data would be crucial in order to be able to make a recommendation on what they should do and how their treatment is going to work, right? So different priorities there for sure. But under that perspective, there's a really major concern with getting it right and ensuring that what is conveyed about Rodney's situation is accurate to make sure that his needs are being met. So we can kind of see how both of these voices and perspectives are coming from a place of care and are coming from an interest in Rodney's overall health and well-being, but because somebody is living that experience in very different ways, whether it's it's somebody issuing a recommendation or somebody that is in that body every day, some of the ways that it plays out differently and sources of this communication and disconnect can definitely start to pop up. So good work on both teams in identifying some of these issues. I think this will be important as we're looking at some of these concerns. So one thing that is a major element of communication skills and developing good approaches to health is this idea of preventative medicine, preventative health, and so on. The idea here is that if we examine costs, right, the cost of surgery and of doing really intensive procedures in the United States, as you could probably imagine, is astronomical, right? Costs are incredibly high and costs increase insurance premiums for everybody. For instance, if somebody has heart disease and is seeking surgical intervention or treatment related to that, you could probably imagine that hospital and medical bills stack up very quickly. However, if we contrast that with behaviors that doctors can prescribe that can reduce the risk of heart disease, preventing heart disease from happening, using education, awareness, or related campaigns to reduce the overall instances of heart disease is way, way cheaper, right? It saves a lot of money. As I mentioned last class, comparing the cost of health insurance and so on in the United States, there's a lot of factors, including there's a lot of discussion surrounding drug prices, including spiking and price gouging related to insulin. But there are also concerns about the amount that we spend on preventative health. For instance, the country of Japan spends significantly less money on health insurance overall per patient, in large part because there is a much greater focus on this idea of preventative health, right? So discussing prevention is not only very economical, very useful, but it also generally makes a much better, less threatening environment for people to communicate and talk together, right? There's a lot of reasons that that makes sense. It's a lot less threatening to talk about hypothetical and ways that you can prevent it, right? For instance, discussing prevention is less emotionally challenging that way, right? You have not received diagnosis for heart disease, which could be an incredibly challenging and difficult thing to grapple with. You are being told you are at risk for heart disease. Here are the things that you can do in order to reduce that risk, right? Part of it is the procrastinator in all of us who enjoys the idea that it's not an immediate concern right now, but sometimes that might be a wake-up call or a sign that there are some health behaviors that we need to change, knowing that we could be at that risk. Oftentimes, providers will let us know that there's elevated risk, for instance, their cholesterol levels are high, to indicate that that risk is coming, right? Additionally, there are studies that suggest that we are more likely to delay our health goals rather than challenge caregivers. In other words, we oftentimes feel more comfortable with preventative health because we're willing to say, okay, I know that I need to cut down on the red meat, and that's a good thing, even though you might not make that change right away. If we know it's preventative, we're less willing to push back. If the doctor says you have to do this now, then we're probably going to recoil a bit and say, no, I'm not changing my eating habits right then and there, right? We can ease into different behavior if we take a preventative approach. And then the last one is just a major concern about agency and options, right? If we're patients and we say, yikes, I am at an elevated risk of heart disease, as a result of that, we might choose to change our behavior. We feel like we can self-advocate and have agency to prevent that outcome from happening over the course of our lives, right? There's a film I like, it's all the way back in 2001, called Frequency, and the premise is that it's like a weird time travel thing. And in the film, the main character is talking to his deceased father from the past. And there's this scene where the father is like quitting smoking and like grasps like his pack of cigarettes and throws it in the trash. And then suddenly he like magically appears in the present because of time travel and changing time so that he was still alive, right? We like that idea, and it can be powerful moment to feel like we can change our health outcomes. So that can be a big part of preventative medicine, is this feeling that we can actually change through self-advocacy. I wanted to share a short clip that talks a little bit about preventative health in a little bit more detail and some of the things that show us preventative health and medicine at play. You're watching, pay attention to some of the ways in which preventative health is at play.
We often think of a doctor's job as solely providing acute intervention, where patients come to us with their problems, and we as doctors fix it. But a doctor's responsibility extends far beyond just solving problems. We have a duty to prevent these problems from happening in the first place. The practice of preventive medicine could save lives, decrease healthcare costs, and decrease health disparities between communities. Today, we're sitting down with Dr. Bivens Domingo, an internist by training and the chair of the U.S. Preventive Service Task Force. Together with some of the country's best physicians, Dr. Bivens Domingo sets the nation's standards for preventative healthcare practice. Let's hear Dr. Bivens Domingo's take on this. Thank you so much for joining us on DocTalks, Dr. Bivens Domingo.
Not at all. Thank you for having me.
What does it mean to practice preventative medicine?
So preventive medicine is the idea that there are things that we can do clinically that help people who are today feeling well, feeling healthy, to continue to feel well and healthy into the future. It's different from identifying symptoms. It's different from treating diseases that people already have. It's really thinking about what we do today to help in people who don't have signs or symptoms of disease to make sure that they continue to be that way well into the future.
What are some current clinical and public health interventions that you're involved in that take aim at chronic disease prevention?
Yeah, so I became interested in chronic disease prevention, particularly cardiovascular disease, because of patients that I had who were becoming very ill or even dying in their 40s. And I started to think of what could I be doing in their 20s that might have prevented this. So some of the work we've been doing has been trying to think about how do we identify who needs to be treated for elevations in blood pressure. How early should we be treating elevations in blood pressure? How early should we be thinking about things like lipid treatments, or who's at risk for having elevated LDL cholesterol contributing to disease? Because I'm focused on earlier in life, it also means that I'm trying to understand the types of contextual things that put people at risk, not just what happens that I can treat in a doctor's office, but what types of things in our environment, what types of things about where people live, work, and play put them at risk for disease that happens earlier.
As the chair of the U.S. Preventive Service Task Force.
Right. So I think kind of as we saw in that interview clip, there's some good examples of preventative work in action. First of all, the idea that through preventative health, not only does it reduce costs, but it also helps to think about ways that, from doctors' perspective, they're concerned about people getting ill and dying and addressed. And it is a matter of kind of ethics and responsibility, ensuring that people are educated, aware about the issues, right? One way of thinking about this is in something like a car accident. Once you're actually involved in a crash, right, in those very short seconds, there are very few things that you can do at that point to reduce risk. There are a lot of things that you can do prior to that point. For instance, having a seatbelt, monitoring the terrain, ensuring that everything's working properly on your vehicle and all of that, right? In the same way, the use of things such as public health campaigns are examples of preventative communication and action. One other thing that I think is good to think about is that it's not just, shaking the finger and saying, you need to have less red meat, right? It might be instead saying, hey, you've been doing a really good job of taking care of your health, your heart rate is really good, continue to do these healthy practices, right? Sometimes good health communication is about reinforcing what people are doing well and ensuring that people understand to continue to stay the course on good behaviors. So there's a lot of different ways that we've talked about in practicing in doing preventative health. As a patient, we might choose to engage in understanding our risks, do regular checkups. For instance, the use of treatment practices related to regular corrective vision might be used. If we know, for instance, we've got macular degeneration. There's a lot of discussion surrounding genetics and about like people who will use DNA testing like 23andMe and similar resources to determine like being more or less genetically at risk. And one of the challenges is deciphering and interpreting that information with a medical professional, because I think there's a lot of information that can be difficult to fully identify in a professional context about genetic markers of risk, right? When it comes to supporting patients, right, and thinking about the concerns that a patient might bring to the table if they're working with a caregiver, I think there's a lot of important things that we need to think. One of them being the idea that for a patient, oftentimes they're going to place or assume stereotypes. If we have stereotypes of who a doctor is or how a doctor behaves, it might be that they come in late, that the meeting is very short and abrupt, that they are not especially respectful. Maybe we think back to the negative experiences that we've heard from friends. Maybe it goes a bit better than we've expected, but we come in with certain assumptions about the experience that oftentimes providers have to try to dispel or break down as the meeting started. For instance, the patient-centered approach, really showing a level of care and interest in identifying and supporting the person in an injury that they're dealing with, might be a way to break down that stereotype from the beginning. Care and attentiveness, of course, are crucial, right? Showing that you care and want to get the details right. There's no worse feeling than going in and feeling like somebody is given like totally different advice, or like the doctor mixes up patients and starts talking about totally different patients, right? One thing that's important for people as patients to think about is this idea that there are no bad questions. Sometimes when we do a meeting with a medical professional, we feel intimidated. We feel like we're asked, we're given a lot of information. Maybe there's some terminology that we're not familiar with. We think that we should be familiar with it or should know it, right? We have to be willing and comfortable with saying, I don't know what this is. I need to understand this a little bit better. And using uncertainty as a way to make communication clearer, right? One of the challenges that we oftentimes have in a lot of different fields, right, for me in communication in particular, is that we might assume the language or jargon that people outside of our field don't know, right? So oftentimes doctors, caregivers will use jargon and terminology that is not common knowledge. And again, that's part of navigating the process, not being patronizing, but also not using language that is inaccessible. Making people, many people will say that they feel pretty good about their care, but they have neutral or maybe negative opinions about their doctors or providers. Again, sounds like a lot of you had good experiences, but it's good to keep into perspective that even if the overall health experience is good, that one-on-one meeting can sometimes feel a little bit abrasive by comparison. So there's another important consideration for us to talk about too. I think it's something that we've been talking around a little bit as we're thinking about some of the ways that power and relationships between patient provider work. And one of the biggest things is the dynamic of that relationship as it relates to a person's injury and their life, right? That patient dignity is a particular challenge because the patient is sort of in a compromised position. For instance, maybe they're on a hospital bed. Maybe they, have IVs. Maybe they've had to be stripped down or have their clothes changed, right? Oftentimes, one of the experiences that patients share, especially if they have serious injuries or conditions, is some level of embarrassment, right? Or feeling like they are kind of being disrespected in terms of their autonomy and dignity because now you're on a hospital bed, wearing a robe. So we have to think carefully about some of the ways that we can respect and support patients that are dealing with those related issues, right? One of the biggest concerns is about this idea of an invasion of privacy. We don't like the idea that a provider has information about us, including information about our medical or personal history that we don't feel like is relevant or important to our lives. So it's important for us to feel like the information that they have about us is what's known and clear. We might use something like an informed consent form to make sure that the information that's being given to a doctor is information we're comfortable having shared, right? Curt and disrespectful communication is another important consideration, right? A health experience that doesn't go well is oftentimes one where somebody feels dismissed or not heard of properly. One example from my own research, right, is sometimes people who have multiple or compounding conditions or experiences have felt like those multiple experiences haven't fully been investigated or thought about. So for instance, for folks who might be kind of in the neurodivergent umbrella, right, ADD, ADHD, autism, there's a lot of similarities and additional diagnoses that might be had. For instance, Ehlers-Danlos syndrome, right, is a pretty common condition that's associated. And so in a lot of situations, people will come and talk about maybe needing support or, digestive health related to EDS. And a doctor will say, well, we're going to focus on ADHD instead, right? Sometimes it doesn't feel like communication is respectful if it's not accounting for the difference in reasons for health conditions that people are looking for help on in that moment. Another idea here is compromised appearance, right? You're in a hospital bed, or you're wearing a robe, or you have a sling or cast, or a doctor or professional is asking you to remove parts of clothing as part of an examination, and that stuff's weird, right? That stuff can feel really uncomfortable, oftentimes because we use our appearance as a form of expression to show who we are and to present the version of ourselves that we want to see to people more broadly. And when we feel like that gets taken away from us, or people are seeing us in a way that we don't want to be seen, that can be an incredibly challenging thing related to dignity as well. If you think about it, right, how would you want your caregiver or doctor to see you? Probably wearing clothes and presenting yourself in a way that lets you be seen as an equal. And we don't feel the same if we find ourselves, sitting on a bed with an IV drip, right? So that can be a challenge too. There's an acronym that can help patients be supportive. It's called ARCPEGS, and I think it's a good way of thinking about some of the stuff that we've talked about so far. One of them being attentiveness. Is somebody paying attention? Do they seem active? Are they using nonverbal communication to reaffirm, to support, to show that there's a level of care? Or are they like multitasking or on their phone when they should be having an appointment with you? Are they respectful, right? Do they show that they care and understand who you are as a person? And there's a lot of different ways for that, right? For instance, people in the LGBTQ community feeling like they're not being stigmatized. Convenience is the encounter pretty straightforward, doesn't work well. If you're waiting a whole long time and the meeting is running late, that can be a threat to that experience and health. Privacy, right? Feeling like an encounter is not overly public or is not involving material that you don't want shared in that situation. Empathy, again, that can be tricky from a caregiver's perspective. But the idea that they at least show some level of effort for imagining possible options to you, right? It's a lot easier to work together as a team to figure out solutions in a patient-centered model when it feels like the doctor has put themselves in your shoes and can understand what considerations you'd be weighing in your options. For instance, Rodney, maybe having 2 months where he has to have the sling and can't go out and play, maybe that's too far for him to go, right? And so maybe the doctor can help find a model for him to get back to playing sooner. A sense of control is important. Again, thinking back to the patient-centered approach, the doctor is not prescribing the option, they're presenting multiple solutions and routes that somebody could go that could support their care. And then genuine caring, right? Do you care? Do you show that you care? And does that come across through your verbal or nonverbal communication? Those are things that oftentimes we look for when we're looking for a good relationship. As I mentioned before, right, one challenge with all of this is that from our perspective, we might not always follow medical advice that we get. And there's a lot of different reasons why. And I think it's important to think about those considerations, both in what's reasonable or maybe unreasonable, right? For instance, oftentimes a patient might find that their recommendation is difficult to carry out. One discussion that I think is important to talk about when we're thinking about issues of class, of race, of rural, urban, and so on, is the accessibility of and ability to make healthy food, right? For instance, there is a term used a lot to discuss the idea of a food desert, or a physical location in which access to healthy food is not regularly available. There's also the fact that a lot of access to healthy food is a lot more expensive. Or making homemade versus processed food takes a lot more time to develop, right? So it's a lot more time to cook and prepare. And so asking somebody to eat more healthily can oftentimes be this sort of hidden way that inequalities start to pop up. So there's a lot of reasons that recommendations can be difficult to follow. Maybe somebody doesn't understand the instructions that they're being given. Another idea here is that the recommendations or advice that's being given is foreign. If somebody, for instance, says you should take about 10 minutes every day to meditate, and you don't know, or you've never really done meditation or know how to do it or what to expect, you're probably not going to follow that advice in the same way. Patients and providers could disagree. In other words, you're not necessarily on the same page about the direction that you should go, which again reinforces the idea that this collaborative approach is important. Sometimes we don't think that something will work. How many people are familiar with what a placebo is? Yeah, few of you. A placebo is used oftentimes in clinical trials and tests. It is oftentimes like a sugar pill, but it's a fake, right? And the way that we determine whether or not medications actually work is we tell both groups, both the control and experimental group, hey, we're giving you this medication that's designed to treat back pain. And if the fake medicine is noticeably different in its effectiveness compared to the real stuff, we know the medication works. So oftentimes we might be worried that the medicine that we're being given is just a placebo or doesn't actually have any tangible impacts on our health or well-being. So if we think it doesn't work, we're not going to do it. And then lastly, and this is an important one, especially thinking about medication that might be taken related to diseases or other conditions, right? Sometimes the side effects that we experience can be too intense or uncomfortable for us, and so we don't want to do that. For instance, there are a number of people who might be diagnosed with cancer and might not choose to go through chemotherapy or through the extensive medical medication regimen that they have to take because of its associated side effects, right? It can be really draining and deteriorating to do, and so many people choose not to do that. How many people have heard of, prior to this class, the Tuskegee syphilis study? Several of you. So we'll get everybody up to speed about this, but I think this is an incredibly crucial and incredibly concerning example, right, of the challenges of informed consent and supporting patients throughout the entire health process, right? This is, along with things like the Stanford Prison Experiment, some of the worst and most egregious examples of unethical communication. Just sort of as a warning, right, this gets into issues related to really negative impacts surrounding health and racialization as it relates to access to healthcare. So I think it's an important thing to look at a little bit more. And I wanted to share a video that provides some context and history surrounding this experiment and some of the reverberations that it's had in overall the ways that we think about health and related issues.
In the 1930s, the United States was ravaged by syphilis, a sexually transmitted infection afflicted nearly 1 in 10 Americans, producing painful sores and rashes that persisted for roughly 2 years. After these initial symptoms, late-stage syphilis was known to cause organ damage, heart and brain disorders, and even blindness. It was incredibly difficult to slow the disease's spread. Experts cautioned against unprotected sex, but the infection could also be passed during childbirth. Worse still, existing treatments like mercury and bismuth were considered unreliable at best and potentially harmful at worst. Today, these heavy metals are classified as toxic, but at the time, doctors were still uncovering their dangerous side effects. Amidst the uncertainty, healthcare professionals had two key questions. Did late-stage syphilis warrant the risks of existing treatments? And did the infected individual's race change how the disease progressed? Many physicians were convinced syphilis affected the neurological systems of white patients and the cardiovascular systems of Black patients. There was little evidence for this theory, but the U.S. Public Health Service was determined to investigate further. In 1932, they launched a massive experiment in Tuskegee, Alabama. The town had already possessed a small hospital, and the area was home to a large population of potential participants. The PHS collaborated with local doctors and nurses to recruit roughly 400 Black men presumed to have non-contagious late-stage syphilis, as well as 200 non-syphilitic Black men for their control group. But their recruitment plan centered on a lie. While the researchers planned to observe how syphilis would progress with minimal treatment, participants were told they would receive free drugs and care for their condition. At first, researchers gave the men existing treatments, but these were soon replaced with placebos. Under the false pretense of providing a special remedy, researchers performed painful and invasive spinal taps to investigate the disease's neurological consequences. When patients died, the PHS would swoop in to study the body by funding funerals in exchange for autopsies. In their published studies, they listed the men as volunteers to obscure the circumstances under which they'd been recruited. Outside Alabama, syphilis treatment was advancing. A decade after the study began, clinical trials confirmed that penicillin effectively cured the disease in its early stages. But in Tuskegee, researchers were determined to keep pursuing what they considered vital research. They had yet to confirm their theories about racial difference, and they believed they would never have another opportunity to observe the long-term effects of untreated syphilis. The study's leadership decided to withhold knowledge of new treatments from their subjects. During World War II, researchers convinced the local draft board to exempt men from their study, preventing them from enlisting and potentially accepting penicillin. The study even continued through the 1950s, when penicillin was shown to help manage late-stage syphilis. By today's bioethical standards, withholding treatment in a research study without a patient's informed consent is morally abhorrent. But for a large part of the 20th century, this practice was not uncommon. In the 1940s, U.S.-led studies in Guatemala infected numerous prisoners, sex workers, soldiers, and mental health patients with sexually transmitted infections to study potential treatments. And other studies throughout the 50s and 60s saw doctors secretly infecting patients with viral hepatitis and even cancer cells. Eventually, researchers began objecting to these unjust experiments. In the late 1960s, an STI contact tracer named Peter Buxton convinced the PHS to consider ending the study. But after leadership decided against it, Buxton sent his concerns to the press. In July of 1972, an expose of the Tuskegee study made headlines across the country. Following public outcry, a federal investigation, and a lawsuit, the study was finally shut down in 1972, 40 years after it began, and 30 after a treatment for syphilis had been found. No evidence of any racial difference was discovered. When the study ended, only 74 of the original 600 men were alive. 40 of their wives and 19 of their children had contracted syphilis, presumably from their husbands and fathers. In the wake of this tragedy and concerns about similar experiments, Congress passed new regulations for ethical research and informed consent. But systemic racism continues to permeate medical care and research throughout the U.S. To truly address these issues, the need for structural change, better access to care, and transparency in research remains urgent.
So very, right, concerning and pretty graphic example of some of the challenges in, of course, major ethical problems in the entire process that led to incredibly hurtful, violent, discriminatory, and racist things in practice, right? The assumption that there were racial differences in how the syphilis was experienced that were unsubstantiated and again have been proven not to be true. And this sort of approach toward race science or the assumption of differences in treatment and care on the basis of race, of course, led to some significant problems, but also severe issues with the process of providing care and providing informed consent. The replacement of medication with placebos, the inability to access penicillin when penicillin is available and found, and also the gap in even finding out about and providing information about this study and the ethical challenges that it has, the collateral damage and impact that it had on children, spouses, and other people that were involved in this study. Right? So obviously, there are an array of incredibly major issues here, but this is a crucial example of the challenges in ensuring that informed consent and support for patients to ensure that everybody is made aware of the healthcare process are crucial, right? It's an example of the impact that a lack of informed consent can have. So informed consent, right, is this approach that we need to be fully aware of treatment benefits, risks, and options that are made available to us. In the Tuskegee experiment, clearly that was not the case because patients were not made aware that the medication that they were receiving were replaced with placebos and not made aware that penicillin was available, right? When you seek treatment, oftentimes you're filling out a lot of paperwork and maybe signing off on it. You're being given a lot of information from medical professionals that comes from a perspective of honesty and transparency. Another component of informed consent is the idea that you're able to understand the information and make a judgment, right? Informed consent, the informed part of it is crucial. It's not just that there's options, it's that you have been presented with the data and information that allows you to decide among those options. So one major challenge for a caregiver is to explain in a way that's clear what the potential consequences are, for instance, of seeking a particular treatment or medication, right? Also, the idea that a patient can refuse or back out of treatment at any time is a crucial part of that informed consent process too, right? The idea that somebody can back out of a study when it's no longer safe for them is an important idea here. Informed consent means that you get to pump the brakes. One of the last things I want to hit on before we take a short break is some of the ways that we relate identity to our experiences of health and related issues. Pictured here on the right is Judith Heumann, who was a major advocate for disability rights and helped to lead passage for 504 and later the American Disabilities Act, or ADA. What is oftentimes encountered for many people who live with disability or illness, in many cases, right, living life in a wheelchair oftentimes means that the way that they incorporate identity based on disability or based on unique health experiences takes on sort of this evolution, right? And you can kind of think about it as stages of grief, although there's other maybe more positive ways to frame it too. There's at first this super normal identity. For instance, somebody is diagnosed with a serious and potentially fatal condition. Oftentimes, we react with a level of denial that says, this is not going to affect me. I'm going to be okay. I'm going to get through this, right? It reaffirms who you are as somebody that's unstoppable. For instance, it's interesting to follow our communication about things like cancer because we'll oftentimes use war metaphors, right? Winning the war or battle against cancer, fighting against it, right? We use that type of terminology a lot. We have a restored self that's still kind of in denial, but is starting to identify that this is a serious and potentially life-threatening condition. You have what is known as a contingent personal identity, that you begin to identify some of the side effects, consequences, or issues that could affect you and lead to a negative experience for you. And then later you develop what's known as a salvage self. That is, your identity metamorphizes or transforms into a new version of yourself that engages with and thinks about the limitations and changes that you might have in your life. And that kind of 4-stage process is how a lot of people who live with major disability or disease or illness have come to reach the point that they have with themselves. That overnight, somebody who has had a major injury does not necessarily suddenly feel great about themselves, but that through that process, they emerge as a version of themselves that feels comfortable with and understands who they are now and how their health has been impacted through that process, right? So all important things to think about when we're engaging with some of the patient perspectives as they relate to healthcare more broadly. So we will take a short break and come back looking at some of the perspectives from caregivers. So it's about 2:55. Let's come back a little bit after 3, so at about 3:05 or so, we'll continue and look at a little bit more from the caregiver perspective as it relates to health. All right. Let's pick back up and flip around a little bit to talk about caregiver perspectives. So I'm going to have us work on a couple of scenarios in your teams again, and just take some time to understand a little bit more about the material experiences and challenges that a lot of caregivers do encounter throughout the healthcare process, right? I wanted to take some time to talk a little bit about what is essentially a very challenging and difficult process to end up becoming a medical provider, right? That oftentimes somebody will go to med school early in the first year or two will typically involve a mixture of taking courses, doing labs that involve on-the-ground training and practice as it relates to practicing medicine and related issues. And oftentimes after that, right, in the third and fourth year, somebody in med school will typically go through the clinical process where they actually start to participate in hospitals or clinics or places to work with patients that are related to their school in question. After that, right, there is an exam, and generally speaking, and I found this kind of surprising according to the Princeton Review, typically people are residents who work in a teaching hospital anywhere between 3 and 7 years, right? So that's a long time to go through that process. And that is in med school alone, let alone the completion of something like an undergraduate program, for instance, we have a lot of people who might choose to complete a degree in pre-med before going to medical school in the first place. So at the end of the day, you're looking at, 7 or 8 years plus, a lot of times, an undergraduate experience for somebody to reach a point where they can really fully practice medicine on their own, right? And putting that into perspective, just as a really long process, I think that explains a lot of the challenges and barriers that people who do take on the work of being caregivers encounter as they're navigating that field. Obviously, depending on the field that you're interested in, for example, a nursing program or working as a physician's assistant might look different from the school requirements, but it's a pretty intense process either way. So becoming a caregiver, right, taking on that type of role and using that role to support patients can be an incredibly taxing and really difficult experience for a lot of people. The kind of irony of it is that becoming somebody who practices health can oftentimes be a very unhealthy experience because there is a lot of stress that can impact mental health, work, cramming, or exams, and an overall atmosphere that can be incredibly draining. We've seen this especially in the context of COVID-19, right? A lot of the frontline workers and people in medical centers who've been especially overstretched and overworked have had some really particularly unique challenges and also fears related to contracting COVID themselves that have impacted relations in health. So oftentimes that process can bring with it those challenges. I should mention that these challenges are not to discourage people who are interested in a career in the field, just to put into perspective the ways that a lot of caregivers come into health communication from as far as their own experiences. Oftentimes, right, if you've taken a class where you have like a big exam that is closed note and book, right, and you've crammed and studied, you've done what's known as rote learning, where it's this kind of in one ear, out the other. You're learning material, but you're not really using or applying or incorporating that material. But problem-based learning is attempting to solve a problem or to address an issue, and is a practice that over time, more and more people who do work in healthcare start to develop. Also, right, over the process of going to medical school, being involved in related programs, caregivers start to develop socialization. They become part of a community. They start to work with professionals. There's what's known as the hidden curriculum, or unwritten rules and norms and standards that they might come to be a part of. We talked a little bit earlier in our team activity about the voice of medicine, the idea that oftentimes this kind of very clinical, focused on understanding precisely what's going on and how to solve the issue can oftentimes be the experience of being a provider, developing that voice. And also, right, that a process can be emotionally isolating, right? You're in a school or program where you don't have a whole lot of opportunities to network or be involved with people outside from the school. That work involves the use of kind of like routine tasks, like, for instance, cleaning out a laboratory. It's oftentimes assigned to students or people early on. And it can bring about intense emotional experiences. There are some kind of harrowing personal accounts of people who talked about their first experience working with a dead body, right? That can be a very challenging and difficult thing for somebody to acclimate themselves to as they're starting to develop their education. Pictured here on the right is Grand Ronde Hospital, right? That's an example. A medical center or facility in our area that works directly with patients on health and related issues. And one idea here is the connections that we see between health and organizational communication. I'm curious, is there anybody here that has taken either organizational communication or leadership communication? Yeah, so a few of you. So that's a field that really examines how larger organizations or groups not only develop a pattern for communicating and relating to each other, but also develop a culture, right? A way of speaking about or addressing topics that ultimately can support the needs of patients and individuals. whether it's the physical layout and setting of the rooms, or the way in which members and employees work together and treat one another. For example, if you were to go into a standard hospital and you could compare it to going into a pediatric facility that works with children, those two things are going to look extremely different, right? Pediatric facility might have like painted art hanging on the wall or on the sides. It might have rooms that are designed to look more fun and exciting. That's an example of how organizational culture and environment could be created based on that situation. That is, when you're working with a provider, whether they're somebody that has their own business or they're working in a larger hospital, right? They're generally people who have their own organizational or hierarchical structure. Organizational process refers to the way in which members of a group do things. It's how business is conducted or done. For instance, we talked earlier in the class about the Hippocratic Oath, do no harm. The idea that medical practitioners have to be focused on preventing harm whenever possible. In a similar way, we can see that the health system in the United States compared to other countries is very different as organizational process. For instance, right, in the United States, we have a lot of health insurance companies. We have discussions over how health insurance is provided. In fact, just a few days ago, there, as I understand it, were efforts to address a gap that existed under the Affordable Care Act that was leaving about 5 million people who should be insured uninsured, right? So there's sort of ongoing efforts in organizational processes that are about how we do healthcare. But culture are the assumptions and beliefs about the organization, right? One of the challenges is that a lot of times, because it can be really emotionally taxing and exhausting to go through the med school process, it's almost a sort of hazing ritual of sorts, right? That people are expected to sort of overstretch or lack a social life or lack opportunities for other tasks because the culture places such an emphasis on solving crises or of addressing issues, right? Again, I would cite the show Grey's Anatomy, if you've ever seen it, as a really prime example of how media might depict these challenges, right? In the show, you have characters who oftentimes are unable to have much of a personal life or things outside of their work because of the culture and intensity that that might bring. So in this way, health organizations, and the way health is provided is shaped by both the formal structural things like laws and rules, but also by the expectations of culture that come with this. When it comes to a provider communicating well, creating a good relationship, we've noted some of the good things that they can do, but to hit on some of the key points again here, one of them is the idea that a good provider starts strong. You might have noticed from the video on Monday, right, that they come in asking questions and showing a genuine care and investment in the person. If somebody comes in and the first impression is that they don't want to be here, then that's a really easy way to feel uncomfortable and disconnected. Avoid interrupting or multitasking. That's an important thing too, right? As a provider, you need to show that you're attentive and focused. You might identify that you're taking notes or you're pulling up a chart as a way of showing that you're still focused on the patient, even if it seems like you're doing something else. Empowering is important. Again, presenting choices or options is a really big core component here. And don't end the visit before you have the opportunity to ask for questions, concerns, or related issues. That's an important way to ensure that a patient has the opportunity to clarify and get their input considered and integrated in the overall process. As a caregiver, you're oftentimes racing against the clock, right? And it's not uncommon over the course of a day to fall behind. And so it's important to think about how to manage and support patients while dealing with that. Some of the stressors, right, what we've started to hit on might include the idea that caregivers encounter burnout. Burnout is a term that's been used a lot in relationship to COVID-19 and the impact that it's had, for instance, on students like yourselves and in terms of professional work. The idea that we feel used up or emotionally exhausted that might come from working with patients on a regular basis. Depersonalization or closing yourself off from other people because of the emotional pain that can come from that, and a reduced sense of personal accomplishment. you don't feel like you're doing your best or that you're achieving the things that you hope to do. Caregivers can also feel economic pressure, especially related to the process of going to medical school and receiving a degree. And there's also psychological factors, including maturity, confidence, and their satisfaction in their job and how they're doing. And that especially can be a challenge and an early portion of the career. And sometimes caregivers find themselves in situations where they're trying to support a patient, but they don't have the resources to do so, or a double bind in which whatever option they have available doesn't seem to be a good option to support the patient with their needs. They could take this medication, but this could be an incredibly stressful and difficult experience, or they could not, in which case the patient could have some severe pain, which in that case is a really difficult issue because there's not the best solution to support the patient's needs. So for a caregiver, right, as I mentioned before, because they're working with so many patients and you think about the hundreds up to thousands of patients that somebody might work with over the course of their career, and you could see where things like empathy might start to be more difficult to regularly practice. One of the ways that a caregiver could choose to relate to patients is this idea of detached concern. That is, that a caregiver cares about and wants the patient to be healthy or to do well, but doesn't feel like they want to get too emotionally involved in the process. Again, we can start to see that as, well, it doesn't seem like you care about me doing well, which could be a cause for concern, but we can see that oftentimes as a result of work, right? The empathic communication model of burnout is an interesting one. It's a theory that's been sort of discussed, but also debated to some extent. And it's a question of who chooses to seek out a career in health or related fields, right? The idea here is that a career in health might be more appealing to people who are concerned about others. Oftentimes, one of the reasons that somebody cites that they want to get involved in healthcare is because they care about other people, which is great. And also might be more able to imagine or empathize with the joy and pain that other people experience. But it also might mean that the very personality qualities that draw people into a profession in healthcare add to the challenge of managing empathy and managing that kind of load and work that come associated with it. So balancing out concern, showing concern without like entirely overstretching yourself is a concern that caregivers have to navigate at a pretty regular basis. In this way, there's what's known as a relational health competence model. And that suggests that communication competence, being a good or effective communicator, means that a caregiver has good social support for both be in their work, having assistants and people they work with whom they feel connected and supported, but also outside of it, having social connections outside of work in their own lives, and emotional resilience, developing over time a tougher shell to manage some of the issues that might come up day to day and week to week in working in healthcare. Again, early on, for people in the field, it can be an especially difficult experience to navigate some of the health issues and intensity that can come up. For a caregiver, right, as we've talked about, and all of the issues and challenges they might be navigating, one idea that's suggested is the idea of a time pie, right? You might think about how you divide up your time over the course of a day or over the course of a week. You might say, I have some time for classes, I have some time for homework, I have some time for athletics, I have some time for like hobbies, I have some time for sleep. One model that I pulled from that some people in healthcare have, right, is clinical time, makes up about a third, administrative work, about 8%, some of that type of management. Time with family and sleep are pretty low, about 70% of time with family, and personal time is about 8%, right? So the way that people involved in health and related fields divide up their time can be really challenging. There's not a whole lot of time to do all of the things somebody might need to live a balanced life. So to manage resisting the urge to put off the good stuff is a good idea. Sometimes like giving yourself rewards at a regular basis can be good. Sometimes, for instance, people working in healthcare will bring in snacks or will do work that is less intense as an opportunity to reward themselves for completing difficult things. Thinking about what makes people happy, of course, and seeking company, finding relationships, whether they're professional or personal, that help to manage and juggle these kinds of issues. Again, this is not to discourage people from working in health or related fields or interested or might already be doing so, just to suggest and put into perspective the challenges and plates that people in these fields oftentimes are having to spin that we as patients don't necessarily think about in the same way when we come in and we work with people in healthcare. So what I want to do now is to give yourself the opportunity to work back with your teams. And I want you to start to write this out in your teams as part of your attendance for today. So discussing some of the concerns that we have about caregivers. So April, I started a new medical residency at a hospital in a large city. But kind of hitting on the things that we've talked about, April's feeling exhausted, overstretched, and maybe isn't even feeling respected by some of her medical superiors and people that she's working with. Given those concerns that April is bringing up, what I'd like you all to start to do as a group is to talk about some of the strategies that April could use to manage her burnout and some of the negative experiences that she's been having. And relating back to the things that we've talked about, what are things that April can do to navigate that difficult experience? So I'll let you return to the teams that you work with at the beginning of class, give you some time to talk about this and to share with us in just a bit what your team sees as strategies that April could use. Take about 2 more minutes to keep sharing and think about some ideas here. Like our teams are about wrapped up here. So let's talk a little bit about this scenario and some of the ways that we can support April to manage this experience. Starting here on this side, what were some of the things that you all came up with?
So we said that she should take a nap today and like spend some time out planning over a walk. Self-care on days off and also to form like with peers. And to identify what you like about the job and like what brings her joy and like what you think. Also have meetings to discuss the environment and create a to-do list so you can like check things off and flush elementally forward to that.
Yeah, these are really good examples of sort of the practices of organization and management that can help the experience feel a lot better. I also think that, you know, as mentioned, identifying or maybe even confronting situations in which, you know, the support is not what it should be, or, you know, maybe the lack of respect is an issue too. Like providing an opportunity for advocacy and support is important, especially in these kinds of things. Here on this side.
We just do the same one, but we have to create the chart so that we're trying to do about that needs to be prioritized. And then he said, find someone outside of the workplace to vent to.
Yeah.
I feel like other times you get within the workplace and suddenly
Yeah.
a whole lot. Everyone's going to do stuff. Yeah. Celebrate the little win. And then have a one-on-one conversation with the superior.
Yeah, all really good examples as well of some of the things to do. A lot of times people in, you know, a lot of fields, whether it's healthcare or not, just find that like having a total outsider who doesn't speak the specific language or have the same framework that you do is such a nice experience, just to feel like you can get out of that for a while and focus on something else. So there's a lot of positive experience that comes out of finding networks and opportunities to work with people. So just some ways to think about some of the challenges, burnout that can come with this sort of line of work from a caregiver perspective. I'm going to have you return back to your teams in just a minute. I'm going to talk about a couple more things and then do a final activity. So one of the last things that I want to get at are some of the situations in which medical care and health can go wrong, right? I think a crucial element of thinking about patient-provider relations is the idea that if there is this level of burnout and work and just managing so many patients and situations, we're going to be faced with circumstances in which something does not go correctly. For instance, there have been awful cases in which somebody's amputated, like the wrong arm or leg, right? Those are extreme examples. But oftentimes caregivers find themselves placed with guilt or responsibility for such mistakes, right? And ineffective communication is a really big reason why medical mistakes and errors tend to happen. Health and science communication are crucial skills for us to develop because they allow us to more effectively resolve and prevent issues from happening. One thing that's important then is to establish trust, right? To create trust between doctor and patient such that it feels like if an event comes up, that it was not intentional, right? The Tuskegee syphilis study was an example of a lack of trust and support mutually. Inviting feedback if something goes wrong, right? Saying, hey, my approach to care was a little bit curt and disrespectful. I apologize. What can I do to better support you? Responding as quickly as possible if there are complaints or issues that come up and how care is being provided or talked about is a good idea. For instance, working with a therapist or mental health professional, you might find that you're not getting what you want out of those sessions. Sometimes it's a good idea to actually say, I'm looking for something a little bit different. Showing care, of course, is important too, just to show that your intention is not to harm somebody else. Creating realistic expectations and articulating what it is that a provider can and can't do, right? I can't cure cancer, but I can do these things that would help you as part of your treatment. Putting in writing what it is that's on offer. For instance, oftentimes with informed consent, one practice is print out or send a copy or to have like online access to something like a chart. Giving referrals can be really useful. Sometimes like a provider can say, this is not my area, but I know some people who are experts in this field that you could reach out to. Thinking about family when it comes to mistakes and errors is important too, right? That an error or problem in the process doesn't just impact you, it impacts those relationships. And that if there's an issue or problem that comes up, that is your fault to take responsibility for it. I gave you the wrong medication. Here's what I can do to help you to ensure that you have the correct one. When it comes to actually disclosing something like an error or problem that might come up, rehearsing or practicing how you disclose the information, saying, hey, I gave you the wrong medication. There was misreading and writing in the office. We mixed up two files. Delivering it in a really truthful and clear way, right? Oftentimes, like we have depicted in media, this very dramatic, like you have the doctor come in and you have the family who's rushing up and trying to figure out, doctor, are they okay, right? There's this way in a lot of situations where there's pressure that people really value direct communication. Avoiding talking and instead listening can be a really important way to pick up on what's happening. Assessing news as it's being received. Maybe things are okay, but the family that you're talking to is concerned. And you need to reassure them that that person is going to be all right. And then using empathy, right? Showing that, yes, you understand that there was something that went wrong that negatively hurt somebody. Somebody might have been more injured or impacted than they should have been because of the medical mistake. When it comes to kind of describing what that issue is, explaining what happened and where, what happened as a result of that error. I gave somebody the wrong medication and that caused their heart rate to go up. You did things to offset the harm, like giving them a sedative. You're saying what will prevent this in the future. In the future, we have a new process for assessing medication, explaining who will take care of the person now. We've got them, taking, they're unconscious, but they're working with us and we'll be able to bring them out soon. Explain the factors that cause the issue, the costs of responding to that issue, and the ways that you can support somebody. We made a mistake, gave them the wrong medication. They are currently unconscious. But we can offer for free to have you all stay at a hotel tonight so that you can see them again in the morning. Doing a kind of proactive way to respond to errors through communication is pretty crucial. The last thing that I want to hit on before I have you complete your final activity for the day is the idea that a lot of times our good communication in patient-provider relationships is not alone, right? That a lot of the work that we're doing is in the context of teams and collaborative work. That sometimes having people that come from multiple areas of expertise and specialization is great. But as we've talked about, if you've taken a class with me, like small group communication, right? Groupthink, or the idea that members of a group start to censor ideas that go against what they see as what the group believes, can be a problem too. But making sure, if you're working together in a group, that you're respecting everybody in the group, what they bring to the table, that you build trust, for example, using icebreakers or other activities to get to know each other. Showing that you're trying to involve everybody in the process. Somebody that comes from maybe perhaps more of a medical clinical perspective or more of a mental health perspective. Both are incredibly valid when we're thinking about health communication in a holistic way. Understanding what everybody brings to the table is important. As we've talked about in classes like conflict management, if you've taken that course before, we know that conflict is not necessarily bad on things, right? Conflict is inevitable, it's what we do as humans. And it can be a good thing by hashing out differences and working towards solutions, and ensuring that a team or group is working together effectively and keeps a good relationship focused on the patient and their well-being matters too. So with some of these things in mind about some of the ways to manage crises and other related events, going back to your teams, I want you to think about a scenario here where Nancy has just should be met with a patient experiencing severe headaches. However, she prescribed the patient the wrong medication, which could cause some major side effects, such as vomiting or nausea, if taken extensively. In your groups, I want you to take some time to think about how Nancy should navigate this medical error and communicate it with her patient. So the patient got the wrong medication that might have some worsening side effects. How can Nancy break the news and share this information with the patient? Like, thinking a few steps ahead, right? They're gonna need this medication, you've got to contact the pharmacy, let's do that now. Let's do the patient. Have 2 more minutes, have somebody ready to share. So go ahead and wrap up and prepare to have somebody share. So let's go ahead and start on this side of the room. What were some of the things that you all thought of how Nancy should navigate this? Yes, yes, your side, yes. Yeah. Yeah. Because that shows like a level of humility and responsibility, right? If you don't feel good about the care here, there are some other options. We're going to make every effort to make this right, but I understand that you don't well. I also like the way you all anticipated like some of the things about driving and related expenses. Again, thinking about voice of medicine versus voice of life role. A lot of times we don't necessarily think from a caregiver's perspective about that cost, about going out and getting the medication, and about, especially with gas prices what they are, right? That might be a really challenging process. So that context, I think, is crucial and shows a level of sensitivity and understanding to the patient that really improves that communication process for sure. How about on this side?
So basically have like the same thing, so we would call her and like notify her of like the situation going on. Medication, also to like apologize and ask for something. And instead of coming again, we would, or they should continue to like explain the situation further and again apologize.
Yeah, so like, apologizing, taking responsibility and ensuring that there is full access to information is really crucial, right? One of the worst feelings is if in that moment, the provider is not as clear as possible as to what's happened. You might feel embarrassed or not wanting to share, but you have to, and you have to do so as fully as possible in that moment. So thank you to both teams for exploring this a little bit and talking about how to navigate some of these challenging conversations. So to wrap up, the things that we covered for today and sort of our focus for this week on these patient-provider relationships, right? I think this information is important because whether or not you are planning on working in health or related fields, the dynamic relationship between a provider who gives care in health and science and a person who is receiving that care is sort of the bedrock of a lot of the things we'll be talking about this term, right? That patients come in with some unique concerns and challenges. How can I address this health issue in my everyday life? How can I make sure that my voice is being heard and supported? How do providers navigate this really difficult terrain of juggling patients, working through med school, doing all the things that they need to do in order to meet the needs of their patients, feeling some of the strain there, And again, this idea that trust and care and well-being and quality of the experience on both ends is a crucial step for people to create that good relationship on both sides, right? So I think that the things we've talked about from this week are really useful context in some of the further exploration we'll do in health and science as it relates more broadly to other patterns of communication. In particular, for next week, we'll be looking at culture and race in health communication. Started to touch on those things a little bit, but not only culture and race in terms of health disparities and related challenges, but also the ways that different cultures and perspectives think about, define, and seek care and support related to health too. That health, because it can be defined in a lot of different ways from a lot of perspectives, also invites a lot of different forms of communication, sensitivity, and care. So go ahead and pass forward your group's attendance work for today. Make sure that the names of everybody in the group are on that. Have a great rest of your week and enjoy the weekend. Remember that you have your week 2 quiz due on Sunday. And we will meet again for class next Monday. So have a great rest of your week. Enjoy the much less angry weather today. We've got some nice sun out this afternoon. And I look forward to seeing you soon.